Nurse-to-patient ratios and patient mortality. Nurse-to-patient ratios are a common complaint among nurses across the nation. Many believe that the patient load that they are required to take is unsafe for their patients. Several nurses also feel that the inappropriate ratios are due to the hospital's attempt to save money. However, it ends up creating poor work environments. Despite decades of research that shows significant correlations between adequate staffing and positive patient outcomes, like reduced mortality, length of stay, falls, pressure ulcers, healthcare-associated infections, readmissions, medication errors, and patient costs, as well as reduced nurse burnout, California is the only state in the United States to have legally mandated nurse-to-patient ratios. PCOT is a format used when creating questions in evidence-based practice. P stands for population, I for intervention or issue of interest, C for comparison intervention or condition, O for outcome, and T for time. The PCOT used in this study was, in patients in acute care hospitals, how does lower to nurse-to-patient ratios, compared to higher nurse-to-patient ratios, affect patient mortality within 30 days from admission? Recent research articles by Chow et al. And Kim and Lee have found, in correlation with multiple previous research articles, that nurse-to-patient ratios, work environments, and the level of nursing education is significantly related to patient outcomes. Regarding nurse-to-patient ratios, there is evidence that there is a 5% increase in the odds of a patient dying with each additional patient per nurse. It was also found that the patient mortality is almost 48% lower in hospitals with better work environments. There was also a 9% decrease in patient mortality with nurses with a BSN degree or higher. Better work environments are defined as adequate staffing, availability of resources, strong nurse leaderships, mutual respectful relationship between professions, enthusiastic nurse participation in hospital business, and a strong nursing foundation. Better work environments also create less burnout and fewer turnover rates, which decrease the nursing shortage. A common reason that hospitals have inadequate or higher nurse-to-patient ratios is because they believe that hiring more nurses will increase hospital costs. However, studies have shown that significant cost reductions were possible through effective staff management. In fact, reductions in overall costs were achieved by increasing the number of experienced registered nurses compared to other nursing staff, like unlicensed assistive personnel. Increasing the amount of registered nurses reduces adverse events like patient mortality, length of stay, and readmissions, thus reducing hospital costs. While increasing the number of registered nurses did initially increase hospital expenses, it did not affect profits substantially afterwards. Nurses at magnet hospitals can enact change by utilizing their shared governance teams to address their nurse-to-patient ratios. Nurses can use the results from multiple studies throughout the 20-plus years, as well as evidence from the literature review included in this presentation that showed reduced mortality can be achieved with better nurse-to-patient ratios, better work environments, and higher nurse education. Nurses can also point out that there is evidence showing that adding more experienced nurses will actually reduce hospital costs while reducing negative patient outcomes. Since California is the only state to have mandated nurse-to-patient ratios and has had them for almost 20 years now, they can be used as an example. Nurse-to-patient ratios should be based on patient acuity with set max ratios for unit type. 1-to-1 for a trauma patient in the emergency department or operating room patient. 1-to-2 for the intensive care unit or an ICU patient in the emergency department, the post-anesthesia care unit, or labor and delivery. 1-to-3 for progressive or step-down unit. 1-to-4 for patients in the ED not otherwise specified, antepartum, pediatrics, the telemetry unit, and other specialty care units. 1-to-5 for medical surgical units. 1-to-6 for postpartum, women only, and psychiatric units, and 1 to 8 for postpartum couplets, 4 couplets total, and the nursery.